From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to today's JAMA Clinical Reviews podcast. I'm Dr. Linda Brubaker, Deputy Editor at JAMA and the Editor-in-Chief of JAMA Plus Women's Health. And today I'm joined by one of our authors, Dr. Marianna Alperin, a professor in the Department of Obstetrics and Gynecology at the University of California, San Diego, where she is also the Vice Chair of Translational Research. Welcome, Dr. Alperin.
Thank you. Thank you for having me.
So today we're going to talk about maternal request cesarean sections, which is a topic that's not familiar to many of our listeners. And Marianna, because we have both worked together as urogynecologists for many years, I'm going to just go ahead and use first names. I hope that's all right with you.
Absolutely.
And let's first start talking about why people have a perception that there is a correct C-section rate, and why is it always too high?
Well, the C-sections certainly have some associated risk factors, and I think that people talk about the high rate because they want to make sure that the women are protected and safeguarded from the risks associated with the cesarean sections. Unfortunately, a lot of the numbers that are being used, they come from the data that include both cesarean sections that are done on maternal request, but also cesarean sections that are done in the emergency situations after the labor had already started for some indications. And there's a little segregation of these two entities. So I think that the rate of cesarean section as being high is something that's paid attention to, as it should be, in order to make sure that women don't have increased complications when maybe they shouldn't undergo cesarean section or don't choose to.
Well, let's talk about what's called a normal, spontaneous, and uncomplicated vaginal delivery with a healthy newborn. There are consequences for the mother during that delivery process. Can you talk a little bit about what some of those untoward consequences might be, the short term and the long term?
Yes, of course, vaginal delivery is not risk-free at all. And in the short term, there's always a risk of the bleeding associated with the delivery. There's a risk to the baby if it doesn't come out easily. And then, of course, there's a risk of damage to the pelvic organs and pelvic structures like the muscles and the connective tissue and the vagina while delivering the baby. And those are the complications that can be associated short term. And then in the long term, this trauma that occurs during delivery can lead to pelvic floor disorders, which are conditions that affect quite a large number of women and for which vaginal delivery is the biggest risk factor. And some of them can develop shortly after delivery, like, for example, urinary incontinence. It's when you have involuntary leakage of urine, for example, when somebody coughs or laughs. And some of them can take long time to develop, for example, like pelvic organ prolapse, when the organs are starting to descend and feel uncomfortable. So those are the risk factors associated with vaginal delivery. There can also be a tear in the anal sphincter, the sphincter that helps us control our bowel continence, and that leads to problems with that. There could be some pain from the tears of the vagina and the pelvic areas, and that pain can be long-term.
And are these consequences typically disclosed during pregnancy to women who are carrying the pregnancy?
Well, it's a great question, and I'm certain that there are many obstetricians that discuss the risks of vaginal delivery with their patients. But unfortunately, as urogynecologists, we see in our practice, many women come in saying that they never knew that this can happen. In fact, there are published data that indicate that 2 to 6% of individuals who have delivery vaginal have post-traumatic stress disorder related to their birth experience, which is, of course, is driven by many different factors, but one of them is people coming in and be saying that they never knew this can happen. Now I can't run. I was an avid runner, for example, and their whole lifestyle changes because of these consequences of vaginal delivery. And I think being unprepared for those is very detrimental.
As a urogynecologist, you're well aware that women don't always talk about these consequences very publicly. There's some stigma associated with bowel and bladder control problems. Does this contribute to the problem?
Absolutely. I think that it is a stigmatized condition. I think that obstetricians and doctors who take care of individuals during their pregnancy have many, many different things to talk about. And the patients potentially don't bring these issues up to them as a concern that this can happen. And therefore, it doesn't become a subject of discussion. And then during their postpartum visits, so when they come in after the delivery of their baby, again, because of this stigma, I think that they are focusing on different things like breastfeeding, and they don't often bring this up to the attention of their obstetrical provider. So most likely the numbers are higher than what we know from the literature.
Why do you think the issue of maternal request cesarean section started? Is it because of these problems or a sense of control? What's the cause for this initiative?
I think that American College of Obstetrics and Gynecology, for example, respects the patient autonomy. Obviously, individuals have to be fully informed. And I think that this respect for the autonomy of the individuals is what drove the recommendation that ultimately, while vaginal delivery might be preferable in many circumstances, ultimately a fully informed individual can make an autonomous decision about the mode of delivery, and that's related to their bodily autonomy. And I think that that is one of the reasons why we even have cesarean section or maternal request, which means that there's no medical indication for it, at least not medical indication at the time of the decision. Also because it relates to the changes in the maternal demographics. We know that while many young women, of course, deliver babies, we have a lot of older individuals who deliver babies, and their risks for those people, for example, related to pelvic floor disorders as consequent to vaginal delivery is much higher than, for example, to someone who is younger and might not have stronger supportive structures of the pelvis and don't have other risk factors for the pelvic floor disorder. So that's another consideration that brings up the subject of cesarean section or maternal request.
Now, of course, there are consequences to cesarean section, just like there are consequences to vaginal delivery. Could you go into some of those risks?
Yes, absolutely, Linda. There's many consequences of cesarean section that absolutely need to be taken into account. For example, immediately there is a higher risk of blood loss, potentially anesthesia-related complications, and like a clot formation. Those are higher immediately after cesarean section. And in the long term, I think one of the very important considerations that should always be taken into account is that when we do scar the uterus, like doing an incision during cesarean section, the more times we do it, the higher is the chances of complications in subsequent pregnancies. For example, placenta can get stuck to the wall of the uterus, and that's called placenta accreta spectrum disorders, and that's presented serious issue where endanger a woman's life even. So I think that taking into account an individual's family planning is really important when presenting these options.
Could you go into a little bit more detail? For example, a person who's planning to have a large family, 4, 5, 6 children, that would be a not ideal plan to have multiple C-sections. Is that correct?
That is certainly correct, because we know that with the increasing number of cesarean sections, we're increasing all those risks that we were just discussing, like placenta getting stuck and potentially uncontrolled bleeding during the subsequent delivery. So for somebody who is a young individual who wants to have many children, I think that that's a really important consideration, and vaginal delivery is probably a much more appropriate choice.
Maternal request cesarean section can be offered by a physician, but it should never particularly be encouraged if there's no medical or obstetric indication. So how does an obstetrician counsel a patient about this option?
Yes, and that is the key, is the individualized counseling. It's really important to discuss all potential short and long-term complications related both to the vaginal delivery and the planned cesarean section on maternal request. And it's important to take into account the individual's goals and also individual's risk factors. Just like we were just talking about, a young person who wants to have many babies, who is thin and who has strong muscles and can recover better than somebody who's older individual who's, for example, only wants to have that one pregnancy. Maybe it was conceived with the help of in vitro fertilization or some assisted reproductive technologies, for example, and it is not planned to have more children. The risk-benefit ratio of planned vaginal delivery versus planned cesarean section are really different for these two scenarios. I think the point of our review with my colleague, with Dr. Amanda Artson, is not in any way to promote a certain mode of delivery, but just to emphasize that we have a large variability among individuals who are pregnant and who are under obstetrical care. And so those individual goals and also individual risk factors should be taken into account when a person is counseled.
So for many decades, women have come with a birth plan and they see their obstetric clinician and they have certain ideas about how they would like the birth of their child to develop. And of course, we all know that no birth is entirely risk-free and immediate severe things can happen at any point in time along that birth process and in the postpartum period. So knowing that no birth is risk-free, it's really important that women have a birth plan that covers the full spectrum of their entire range of options. Are there patients who really should strongly consider cesarean delivery instead of vaginal delivery? And who would those patients be?
Again, I think that the individual choices is the most important, but in theoretical scenario, whom we certainly this subject should be brought up with, for example, an older individual who is not planning a large family, who already potentially has risk factors for pelvic floor disorders, which, while those don't cause death or mortality directly, they are really morbid and certainly impact a quality of life, could be lifelong negative impact on quality of life. So I think those needs to be discussed. Some people already have other risk factors that are going to be superimposed on this trauma that is experienced during vaginal delivery to their pelvic structures. And that can be that they're heavier, that they already might have some pelvic floor disorders. Again, age plays a big role. And so then with the modern anesthesia and a modern infection prophylaxis that is used during cesarean sections, while the complications are certainly some are higher than vaginal delivery, some are lower, but overall it is a safe procedure, especially for that delivery, not talking about the future pregnancies. So for the individuals for whom complications related to future pregnancies are not a big concern, maybe they will never have a future pregnancy, the consequences of vaginal delivery and their mainly effect on the pelvic floor that can be lifelong, that risk is much greater than the potential risks of cesarean section. I think that those individuals especially need to be presented with these options.
And just one last aspect that we should discuss is when an individual has a maternal cesarean request and it's mutually agreeable between her and her obstetrician, there's a plan for an orderly, timely, well-planned cesarean section without labor. It's cesarean sections that come after many hours with labor that have the highest risks associated with them. But as you've mentioned, when you're planning an elective cesarean section, and things are well controlled and anesthetic is optimized and everybody is in position, the risks are relatively low for those individuals. Never zero, though.
Absolutely. And they're very low, but not zero. And of course, American College of Obstetrics and Gynecology and other societies internationally state specifically that those cesarean sections on request should not be done before 39 weeks of pregnancy, unless there's, of course, some medical indication, then it's no longer elective. So definitely not before 39 weeks.
Is there any aspect of this that we haven't covered that you want to touch on?
I just wanted to mention, many people think that women don't have control or feel like they have much less control when they undergo a cesarean section as opposed to vaginal delivery. But in fact, there are studies that surveyed individuals that show that women who want more control of their delivery, they actually prefer cesarean section. And there's definitely studies that indicate that there are more satisfaction with their delivery experience overall. Again, this is very much needs to be discussed on the individual basis, but I think there's a lot of misnomers associated with the cesarean sections.
Thank you very much. I want to thank you and Dr. Artson for contributing this work to JAMA. And Dr. Alperin, thank you for your continuing work in this important space of women's health. This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.